working here at Ombudsman. Thank you, Manisha.
Thank you very much, Rachel. Thank you, Mr. Agarwal, for this invitation. Thank you very much, panel, and thank you everyone staying back on a Friday. Doesn't sound like an exciting topic, but I hope I can incite some discussion and some key messages to take home. Right, so the basis of my talk is, I just reflected back what is the basis to say about something this is not very commonly seen. That I've been blessed to be working with one of the best and one of the biggest bariatric surgery unit in the UK, and that's why I have the privilege of focusing on certain things which can be overlooked in other areas. So I've been with the unit since 2020 and almost seen around 6,000 outpatient encounters, 475 patients as inpatients. And I try to support my bariatric colleagues for management of chemical pathologies, which can include trace metal deficiencies requiring parenteral infusions. Apart from them, because of the increase in bariatric tourism, I'm also getting a lot of calls and queries from the GPs where surgeries have been done abroad, and these are not as standardized or as well known, or we do not know the surgery details, so the patients are presenting to the GPs with unknown symptoms, and it's difficult, and sometimes it's difficult to even find the surgery operation details to see how the gut has been dissected and what has been the alteration. So, why bariatric surgery patients are different from others? They are different because they have a different gut anatomy, physiology, and biochemistry. And their intake in terms of oral intake, food, and drugs absorption is unpredictable. Also, there is change in pharmacodynamics and pharmacokinetics of drugs. So, we are actually dealing with human beings where we do not have books to refer, or we do not have much, we can only go by patient to patient basis. It's also received after a long period of obesity with multifactorial reasons, with deep psychological issues leading to disconnect from physical well-being and huge component of self-neglect and, if not, self-harm. Trace metal deficiencies are not part of routine clinical diagnostic pathology workup in the UK, and I guess in other countries as well. And the test is not routinely available unless the patient is sent to a dermatology unit or a neurology unit. So these trace metal deficiencies, which can be common pre-operatively in bariatric surgery patients, are usually missed. And also the factor which limits their use and utility in diagnosis and management is that they require special tubes. Because trace metals, by the nature of their name, they are small in amount, so they can get erroneous results because of contamination. So they need right tube, right technique to get the right result. And apart from that, the right interpretation of these results also is most important, because we cannot be just working on numbers which are released. So these are my colleagues who have seen this figure and others in the audience. Just to highlight in a different way that these two patients' stories suggest fantastic clinical outcome, but in terms of quality of life, the first one on the left, successful throughout, she's fine. This one, she has almost gone back to the previous weight because of difficult to manage trace metal deficiencies and multiple hospital admissions, and so the superficial picture doesn't say it. Some of the things which can present as clinical manifestations in trace metal deficiencies can be excessive hair loss, and like a lot of referrals that I get in my clinic are excessive hair loss, or they have got anemia which is not responding to oral iron or iron infusion, or neurological symptoms they can have. So I will be presenting two cases where these patients, two of them were wheelchair bound. So this is actually this case some of you might have seen, but I'm trying to reinforce that this was the first case in 2014 which excited me towards getting involved with these trace metals. Deficiencies in bariatric surgery patients went on to get a special license for getting this service in Homerton. So this patient, 51-year-old, she had sleeve gastrectomy and gastric bypass in 2008 and 2011 elsewhere, and she was referred to our hospital. She was wheelchair bound, and her feet were like this, completely dorsal flexed with spastic paresis, and she was not able to walk. She was wheelchair bound, for 3 years. On examination, she had proximal muscle weakness, bilateral spastic paresis, proprioception was markedly diminished, and she was unable to stand. When we did the blood test, as you can see, ceruloplasmin, which is the copper carrier protein, was very low. MMA, which is a functional marker of vitamin B12 deficiency, was high, suggesting functional deficiency of B12, which is not visible on a standard B12 test. And thyroid function normal, vitamin D high normal. So this patient was actually living in a nursing home, not taking her supplements, but for some reason she was high on folic acid because of some personal bias and vitamin D, but other things were everything, multivitamin, everything was missed. So you can see, because the title of our talk is it high cordiality? This is a real photo from the EPR showing this patient had these levels. A copper of 3.5 and selenium of 36.9 when the normal level was more than 80. So these were other markers where she had normal zinc, vitamin A, thiamine level, and she was erroneously treated for thiamine deficiency, thinking her symptoms were for one case encephalopathy. We as bariatric surgery unit are very prone thiamine information as vomiting, thinking the result is less, but in this case it was not helping at all, and that's why this patient came to us. So this patient had severe functional B12 deficiency with folate overdose, and again we know folate can mask vitamin B12 deficiency, a very innocuous molecule, but still can cause devastating side effects. And then we are always wondering, because with bariatric surgery patients, we all know the GPs or other specialists, they will say, this is a bariatric surgery patient, you deal with it, because everything seems to stem from bariatric surgery. And but sometimes it can be other age-related health issues as well. So this patient had copper, selenium deficiency and depleted iron stores. Once this patient was treated with long-term admission with multiple series of copper and selenium infusions over 3 to 4 weeks, she started improvement. She had marked neurological improvement, proprioception regain, and patient could walk with crutches after 3 years. But yes, absolutely, like one of the previous panel members said, without a multidisciplinary team approach with robust dietitian, physiotherapist, and surgeons, everybody, all of us coming together, this was not possible. I include this example every time because still after 12 years, after 11 years, we still see patients, we still have to admit them in the ward for infusions, and somewhere something is missing, which needs to, because we also get referrals from other places. This borderline personality disorder, where I say diagnosis being reviewed, is an old slide. Actually, the diagnosis was reversed, which was a big breakthrough for this lady, because she had gone through divorce and everything because of this particular diagnosis. So that diagnosis was reversed. She did have borderline personality disorder. She's a normal female. She went on to go on with her life, and even got the slimmers, slimmer ear, the ear ward for slimmers, whatever that organization is. And she's living independently in her own home. She was, imagine somebody living in a nursing home for 3 years, and now she lives independently, fully functional, and even had abdominoplasty. Is it already 8 minutes gone? Okay, I will skip this theoretical part. Coming to the most, I think this first case was a repetition, but I got to know that there were many new trainees, so I involved this. So 51-year-old female patient, pre-op BMI of 45 with diabetes of 7 years, hypertension. She was euthyroid preoperatively. 5 years post-surgery, BMI 36, fantastic response, diabetes and hypertension resolved, but she developed subclinical hypothyroidism. She had symptoms of cold intolerance, recent weight gain, she was not happy, and significant hair loss. She looked up her symptoms on ChatGPT because she was not getting an appointment with the GP. She started taking her mother's thyroxine, 25 micrograms, and her PT4 was 15, as you can see, within the normal range, and TSH of 7, which is high, suggesting subclinical hypothyroidism, so she was more convinced to take thyroxine. Repeat TFTs showed the same response. Then when we did the chemical pathology workup, she showed low folic acid, low iron stores, and very low selenium levels of 0.4, normal range is 0.8 to 1.5. Her free T4 was normal, but her free T3 was mildly low. Her TSH was still 6.4. So we started patient on all supplements, and then 6 weeks after selenium supplementation, her levels dropped to 0, have increased to 0.6. Then I increased the dose further, and with sequential increase of selenium, because there is no parameter, you have to just monitor the level and see clinical improvement. She had her selenium level normalized and her TSH normalized without thyroxine. So, and clinically, the most important part was clinical. Her hair fall completely stopped, she lost 2 kg weight, her cold intolerance stopped completely, and remarkable improvement. So, selenium is something that is required for thyroid function. Selenium is required for conversion of free T4 to active form, which is free T3. A patient can have selenium deficiency impacting the thyroid function, where she can be erroneously started on a thyroxine dose, not realizing that selenium is the culprit. And selenium is just one part for thyroid hormone synthesis or conversion. So we have to keep in mind and join the dots. As you can see, it has got multiple roles in cardiovascular, antioxidant, and yes, if you go on a molecular level, it is also cardioprotective. Coming to my last case, 38-year-old female patient with UMI
Sorry, Manisha, we're at time. I'm so sorry.
Right. Can I come to the conclusion? Just the reals, just to show it is not a hype, it is reality. You can see the levels of copper, the selenium, and zinc, and how they improved with serial infusions. The patient was again wheelchair bound, no energy. She sat in the clinic and she said, I wanted to die. And then I had to call my surgeons, who very kindly got her admitted on the spot. And then she improved a lot. And you can read quickly, but yes, from wheelchair bound state to being discharged after a few weeks of hospital stay, and now being monitored in long-term follow-up clinic. So summary, trace metal deficiency is very real. Correct phlebotomy using right trace metal tubes to avoid enormously high levels. Never send your trace metal samples without a full blood count, CRP, LFT, and renal function, because the biochemist will not be able to interpret and you might be acting on wrong results. And clinically correlate. If a thyroid function doesn't make sense, check for selenium in bariatric surgery patient. If iron profile is not improving with oral iron infusion, check for copper, because copper has got impact on iron metabolism. And zinc with very low zinc, and because zinc is albumin mount, if a patient has got hypoalbuminemia and your zinc is mildly low, you don't need to treat it because there is a correcting formula. I just want to introduce one of my lead chemical pathologists. Very rarely we are two in one room. So Anita Sarkar, she's from Edinburgh Hospital, and I met her first time and I was very happy. Thank you so much.